live.
A lot of shadows. Okay, Dr. Deukmedjian, we're here getting ready to do a Deuk laser disc repair. Cervical. This is our patient, and she is asleep. She's laying on her back. This is the front of the neck. The Adam's apple's here. The chin is here. The chest bone is here. The legs are down that way. And of course, for cervical surgeries, our patients are always asleep and intubated. So she has a tube in her throat. We're just going to get started here. Let me see, shot. So 2, 3, 4, 5, 6. You all agree?
I agree, sir.
Let's go AP. So to do the cervical laser, Deuk laser disc repair surgery that we're doing, we need to get a needle into the disc. That looks great. Go back to a lateral. And we want to do that through the front of the neck. We do our surgeries through the front. They're called transdiscal. Much better than going through the back. Shot. All right, so let's check our AP again. 2, 3, 4, 5, 6. Luis, you agree? 5, 6.
I agree, sir.
Shot. Perfect. So we're right in the middle of the spine. Go back to a lateral. Now this patient has a herniated disc at C5-6. It's bulging and herniated. A bulge is a herniation. Shot. So now we're in the middle of the C5-6 disc. I'm going to verify my position on the lateral view. We're perfect. The needle tip is at the center of the disc at C5-6. I can see the number 2 bone, 3, 4, 5, 6. And on the AP, we're in the center. You can see the spinous processes. The spine is lined up perfectly. So this is absolutely perfect positioning. So everything starts with accessing the damaged disc that we'll be operating on through an anterior approach to the front of the neck. And I make it look easy. I realize that. But don't try this at home. It actually takes an incredible amount of skill and training to be able to do what I just did, just placing the needle. And the reason is there's literally a millimeter of space in the soft tissues of the front of the neck that I can pass through to gain access to the spine. Coker. Specifically, I'm actually working, no, we're okay. We're working medial, which means towards the midline. In medical terminology, we're just medial to the carotid sheath, which has the carotid artery, the vagus nerve, and the internal jugular vein. And we're lateral, meaning to the side. We're side of the esophagus and the trachea. All right? You can actually see there's a tube in the esophagus that's braided. It's a temperature probe. And then you can barely make out the endotracheal tube because we're a bit overexposed. Let's underexpose a little bit so people can see a little bit better. Go ahead and underexpose, much less. It's fine. Go ahead and point with your arrow to the endotracheal tube. Yep, that's the endotracheal tube. And then point to the esophageal temperature probe. There you go. All right, and you see where the esophagus is right in front of the spine, and then you see where the trachea is in front of the esophagus. Okay? And then, of course, the skin is way out here. So I'm about to do a discogram. Let's go back to the image. I need a little shoulder pull on both sides, Luis. Can you do that for me? And we're going to inject some dye into the disc. Ready? Shot. Let's just see what we got. Perfect. And here comes the discogram. Shot. There it is. Look at the tear in the back of the disc. Right there. That's what we're after, folks. That's what causes neck pain. Right there. Beautiful. There's the dye leaking out. You show them the tear just to the left of where you are. Yep. There. That's the annular tear. That's where all the neck pain comes from. Who discovered this? I did. At Duke Spine Institute. Let go of the shoulders. We're good. Why do I say that? Because when you go talk to your doctor about fixing your neck pain, they're going to look at you funny if you start talking about annular tears and inflammation. They have no clue what you're talking about. And I really mean that. Modern medicine today in the year 2021 does not understand the cause of neck pain or back pain. And when I go online and talk to people about curing their pain, they think I'm nuts. But we do it every single week. We cure people's pain by doing this repair of the tear. And Deuk laser disc repair is the only surgery in the world published and done to repair that tear. All right, so I'm going to put my guide wire. I want to look on my lateral view and make sure I don't put it in too far. And now that I got my guide wire in, I'm going to take the needle out. But before I do that, I want to make sure my blood pressure is good. Actually, the patient's blood pressure is good. And it is. Here we go. So I'm going to take this. Oh yeah, we need to numb up the skin. So I'll do a little. We're going to do a 4 millimeter incision. That's all it takes to do this surgery. 4 millimeters. That's like a pimple. A pimple size incision. Pretty amazing stuff. But still, we give a little bit of local, about 1 cc. And the reason is that as I make the skin incision, the patient can still subconsciously feel pain, and they can respond. Their heart can respond by increasing its rate. And we don't want any responses. We want to keep everything stable. So we want to keep the heart rate stable, the circulation stable. Anesthesiologists shot, they like stability. So do surgeons. All right, here comes our 4 millimeter incision right at the entry point of the guide wire. Let's see, is that enough? And I don't go deep. You never want to go deep. It's literally a tiny little stab incision. Yep. And I want to make sure the guide wire hasn't moved again. Quick shot, you're pulsing, right?
Yes, sir.
All right, so what are we going to do next? See this tube? This is called the dilator. It comes from Germany. It's FDA approved in the United States. And thank you. The purpose is basically to create a spreading of the tissues, spreading them without cutting them. When you cut tissue, they bleed and they scar. You get scar tissue. When you spread tissues, they don't bleed, they don't scar, they don't get damaged. So quite literally, the only damage we've created in this patient is the cut on the skin, right there. That's it. That's the only place there'll be a scar, in the skin. Everything else below is going to be perfect. And we're going to go fix the bad part of the disc, which is the back, the annular tear and herniation. So all other types of surgery, except for the Deuk laser disc repair, cause damage to the spine, damage to the body, scar tissue, and other complications. So basically you can see the dilator on the lateral view. And once again, we're going for the C5-6 disc. You can see how well preserved the disc is. It's got a nice height to it, similar to the other discs. It's not really collapsed. So this is an early intervention for an annular tear and herniation that's causing neck pain and headaches and arm symptoms down her left arm. And what we're going to do is we're going to go in there and we're going to clean up that tear so that it will heal properly. And as it heals properly, guess what happens to the inflammation? It stops. Inflammation destroys your body. As long as you allow inflammation to keep going, it will destroy tissues around it. So our goal here is not just to get rid of her pain in her neck and her headaches and her arm symptoms, but it's to stop the inflammation that's destroying her disc. It's shocking to me that scientists around the world are trying to scratch their little heads and saying, why does degenerative disc disease occur? They have no clue. It's like a mystery. And yet it's so obvious. It's an inflammatory condition of the joint. And just like an osteoarthritis of your knee or your hip, the joint collapses over time from the arthritis. Arthritis is destructive. It's like a war going on inside your disc, in the back of it. And that destruction destroys the entire disc over time. It takes years to do it. But that's the source of degenerative disc disease, is the annular tear with inflammation. And we're going to go fix that right now. All right. I'm slowly bringing my dilator down to the front of the spine by twisting it. Look how tiny that little hole is in the neck. Isn't that wonderful? Shot. And by the way, there will be no fusion. There's no screws or plates or anything. What's wrong? Oh. So we're at the front of the spine. I could feel it. Go ahead and get an AP. I've been checking our guide wire. It hasn't moved. I'm going to hold the dilator with our coker, and we're going to get a quick shot from the front to the back to make sure we're in the middle of the spine. And we are. You can see the tip of the dilator is right where the spinous process is in the middle of the disc. That's the most perfect spot to be. You want to be in the middle of the spine, in the front of the spine before you enter the disc, because that's where the anterior longitudinal ligament is. And just to the side of that, about 3 or 4 millimeters on each side, starts the longus colli muscles, which if you enter there, there'll be bleeding, there'll be possibility of damaging the sympathetic trunk, which runs inside. So you want to enter the spine in the midline. That's why we check an AP. Okay? Very important. So I'm going to keep advancing now through the front of the disc. And again, I'm not cutting anything. The only thing I cut was the skin, and it's 4 millimeters. So it's the smallest incision in surgery. This is true minimally invasive spine surgery. There's nothing less invasive, and there's nothing in the world that works better than this surgery. No fusions, no ACDFs, no discectomy, no laminectomy, no microdiscectomy, no posterior cervical laminotomy, laminoplasty, foraminotomy. None of that stuff comes even close to the success rate of eliminating pain that the Deuk laser disc repair achieves. This is the future of spine surgery right here you're watching. Unfortunately, most spine surgeons are motivated to do fusions and artificial discs because they make a lot more money doing those procedures. And they don't do endoscopic surgery because they don't know how, and because the companies that sell screws and plates and cages are in their ear all day long with their reps, getting these surgeons to try the latest screws and plates and everything else. Shot. All right, so the dilator is at the back of the disc, right where the tear is. It's actually gone through the tear. And the beauty of it is going through the disc doesn't damage the disc because the disc is jelly. So we're actually passing through the jelly. It's harmless. The jelly has no nerves in it, no blood supply. It's just a neutral jelly. It's a compression jelly. And we're not removing it. We're just spreading it like everything else. And I'm going to bring my tube down. The whole surgery, for those of you who've never seen this done before, is done through this beautiful little tube. Ingenious. And really, I learned this basics of the technique from the Koreans and a German surgeon. And I've actually pioneered the rest of the technique. And that's why it's called the Deuk laser disc repair. It's been peer reviewed and published several times as safe and effective for the treatment of disc bulges, herniated discs, degenerated disc, stenosis, radiculopathy, neck pain, discogenic pain. Shot? All right, so I've got to bring my tube down, and I may have to make my incision the tiniest bit wider, but I don't think I will. I'm going to, oh, I got past it. Shot? All right, so here we come. Literally a 4 millimeter. The tube is 4 millimeters wide, and the incision is 4 millimeters wide. So that's why it's a Band-Aid surgery. And because I'm not removing the entire disc to get to the little bit in the back, the part that's damaged, because I'm not taking the whole disc out, we don't have to fuse, we don't have to put an artificial disc. The patient didn't want an open surgery. She wanted endoscopic surgery. And that's exactly what she's getting. The most advanced spine surgery in the world, without metal, without fusion, without metal discs or anything else. All right, my tube, as you can see on the lateral x-ray, is sitting in the front of the disc. So now I'm going to advance this tube through the disc to the back where the tear is so I could debride the annular tear. Luis is going to gently retract the shoulders so that I can have a perfect view on the x-ray as we go down. Not too much, not too much. Shot. Doctor, would you mind pulling on the head in a little inline traction, just gently? Relax the shoulders for a minute. Slight extension. A little more extension than that. I would, yeah, there you go. And then give me a little tug, just gentle. Ready? Shot. All right, so here we go. Shot. Yep, nice. I'm gonna have to advance the dilator. You guys can, you can relax, Dr. Rafferty. Shot. Luis, I need you to stay with me.
Yes, sir.
And you just have to pay attention as you're doing this. You don't want to advance the dilator. Okay, so the dilator snuck back, kind of like a bouncing of a rubber ball against a wall. I just have to put it back in. You don't want to advance your tube without the dilator shot, because the dilator is playing games with us. Shot. You don't want to advance the tube without the dilator, otherwise you'll biopsy the disc, and that's not what we're here to do. Shot. Oh, sneaky. Shot. I think we're good.
Yeah, yeah.
Perfect. All right, I could bring it down a little more than that. Good. All right, we're good. So now what we're left with is the small tube that we're going to do the whole surgery through. The name of this is a tubular retractor. Now this is the only place in the world you can get this anterior cervical Deuk laser disc repair right now in the year 2021. Eventually we will open centers around the world to treat people with chronic back and neck pain. But that takes a lot of money that I don't have and time that I don't have by myself. But Luis is ready to travel. Right, Luis?
Yeah, we have the cases and everything.
Especially if there's a beach nearby.
Yes, yes.
All right, very good. So we're going to bring our scope in. You ready, Luis? And just to show the audience, you want to show them the scope here? Can you see it?
Yeah, they are seeing the scope.
So the scope is this long metal rigid tube and this handle and the manifold. We call it a manifold. We've got irrigation going in that's cold. The other port we need to close. And we've got the laser fiber going in here. And then we have our camera here. And our light source here. The light source basically is just that. It creates high illumination so we could see at the end of the scope what's going on down there. You'll see what I'm talking about in just a minute.
You ready, buddy?
I need my irrigation on. Thank you. All right, so here we are. I need the irrigation on. I don't know why it's not on. There we go. That looks good. All right, I'm going to adjust the focus. There we go. Now you're not going to get as good of a view with this scope as you would with the lumbar because it's a fiber optic scope in the cervical spine, which is what we're doing now is fiber optic, and the fiber optic view is not so good. Not as good as a lumbar. And the reason is the lumbar is a rod lens. This is sticking a little bit. It may need some milk.
Okay. That's okay.
All right, so let's head back down,
Can we have
turn on my
these,
irrigation.
light off, maybe this one?
And there's the herniation, okay? I probably will need a little bit of light down, maybe 2 clicks on the intensity. And you're at 20, correct?
Yes, sir. 20.
All right, the laser fiber's at 12 o'clock right there, and we're at 20 joules. And once again, it's just a matter of using the laser to remove the herniation, which is the blue stuff, and also to clean up the annular tear. So that's what we're going to be doing. Now, Diego, why don't you show our audience the animation on how a herniated disc causes pain in the neck or the arm through inflammation.
Injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have
All right. So while you guys have been watching our animation explaining what we're doing, I've been just doing the repair of the disc. Once again, to orient you, at the end of this metal ring, oh, that's a nice herniation piece. At the end of this ring, which I'll take you down to show you, right down here, the end of this ring is the end of the tube. And the end of the tube is literally at the back of the disc, where the tear is. Now off to the left is the end plate of C5, and off to the right, the yellow thing is the end plate of C6. So between the end plates is where the disc is. That's what discs are. They're between the bones, the vertebral body. And this is the herniation right here. And you can see there's a lot of damage. Now what's interesting is there may be some fibers of the posterior ligament starting to be seen there. But we're pretty much in the middle of the disc, and that's where this is a big central bulge. And I'm removing the fragments of herniation, and I can kind of faintly make out right there some of the fibers of the posterior ligament running up and down, north and south, left to right, right basically, which would be up and down. There's a piece of herniation there. Okay, and you can see the annular tear, this white thing. That was the top part of the annulus. The left side is the bottom half of the annular tear. There's some more tear right there. See that? See that crack? I'm cleaning the tear. And I think there may be a piece of herniation in here. That's the foramen, the neural foramen. Oh, there, you can see it right down there moving. And a lot of time, oh, there was a piece that came out. There's still more. It's going to come out right now. But these, oh, look at that. These fragments of herniation in the foramen, they're frequently scarred in there from chronic inflammation, just scarring them to the annular tear. And that's what I have to do, is I got to free them up. Otherwise, they're not coming out. And that's what the laser does. So people make fun of the laser, you know. A lot of surgeons don't understand how the laser works. And they don't know how to use it. They've never used it before. Lasers are advanced tools in spine surgery. And 99% of spine surgeons, if you ask them about the laser, they're going to say, what are you talking about? They don't know anything about it. So they're not going to recommend surgery they don't know about. So don't expect your friendly local spine surgeon to be able to inform you on the more advanced technology in spine surgery, because they actually don't know. They don't know they don't know though. Or maybe they know, but they don't want to tell you they don't know, because they don't want you to lose faith in them. But see, I have no problem telling you I am not a cutting edge surgeon when it comes to aneurysm surgery. Okay? I'm not. And if I have a patient with an aneurysm, guess what I'm going to do? I'm going to send them to a surgeon that I know is really good at doing aneurysms, that's safe and has a really good track record of fixing them. That's the right thing to do. It's called a referral. And doctors refer, but sometimes they let the money or the fact that they're not going to get any money, because you can't get paid for a referral. That's illegal. Some doctors, you know, they still break the rules, but most, oh, look at that herniation just came out. Most doctors are smart enough to know not to break the law. And so they don't try to get money for referrals. But the truth is that you're supposed to refer your patient That's all part of the herniation right there. Big one. You're supposed to refer your patient to a specialist who is better than you when your skill level or ability to care for them, the patient, for that problem is not at the standard or at the highest level, okay? And that's really a personal choice that surgeons have to decide. That's the herniation. That's a big part of it right there. That's the central herniation in the middle. That's one of the reasons we're here, is to get rid of that, as well as a foraminal herniation. You see what a nice job the laser does? And I'm controlling the laser with my fingertips so it doesn't go too far, okay? Because that's a spinal cord down there. We don't want to go too far. Getting in the spinal cord is bad. We don't want to get in the spinal cord, okay? My point is simple. If your spine surgeon doesn't know how to do the most advanced endoscopic surgery to cure back or neck pain, they should refer you to somebody like Duke Spine Institute who does. Just like I refer patients to neurosurgeons and orthopedic surgeons when the patient has a problem that I'm not the best person for them to treat, okay? You can't expect a neurosurgeon to be good at everything neurosurgical. We're not. We specialize. Of course, we're trained to do everything, but by the time we get out and get into our practices, we really focus on certain things. For me, it's spine, and specifically degenerative spine conditions like disc herniations and stenosis. That's why I'm always operating on disc herniations and stenosis, okay? Pinched nerves, that's what I do. But some surgeons, for example, treat tumors and cancer of the spine. That's not something I routinely treat, and I would refer my patient who has spine cancer, I would refer them to a surgeon that does spine cancer treatments all the time, because that surgeon's going to be much better than me at fixing their problem, safer and better. You understand? And that's what doctors need to do. So the truth is, most spine surgeons don't know how to cure neck and back pain, so they shouldn't be treating it. They should be referring the patients. Pain management doctors don't even know how to cure neck and back pain. So they shouldn't be treating it beyond what they can do, which is treating facets. But this whole concept of giving people pain pills for their pain because you don't know how to fix it, that needs to stop in a bad way. It really needs to stop. Boy, this disc is just seriously blown out. I mean, I cleaned the whole back of the disc off, and now you can see there's still more herniation. We're going to get it all. Now we're leaving 95% of this disc here, okay? We're only fixing the tear, that's the tear right there, and we're removing the herniation that's inside the tear. And that we're just about done. We've got about 5 more minutes to go, Dr. Rafferty. These are all pieces of herniation I'm floating out. By the way, any questions from our audience?
Yes, doctor, we have one question from Facebook. Do you need a COVID vaccine to see the doctor to have the surgery?
Do you need a COVID vaccine to see me, Dr. Duke, or Duke Spine? The answer is no. We don't require COVID vaccine on our patients. We do require that you don't have symptoms. Obviously, we don't want you here when you're sick, spreading any kind of disease. But no, we don't discriminate against people who don't have the vaccine. It's not for us to say people should be vaccinated or not. I recognize that some people won't like that answer, but that's the truth. I'm in the business of telling the truth, whether it hurts us or not. But the good news is we've never had a single patient here get COVID at our facility. And the obvious reason is we don't treat COVID here, so we don't have COVID patients, and we do our screening really well.
Yes, that leads us to our follow-up question. Someone from YouTube says they just had their C3 to C6 neck fused, but their next operation got canceled due to COVID problems. He wants to know, are you having similar problems in your institute?
So I think I understand the question. This person saying that their surgery was canceled because of COVID Something about COVID?
Yes, they're having COVID problems where he's having his surgery
No,
done.
we don't cancel our surgeries. We are treating patients. You could see from watching our videos, we treat every Tuesday and Thursday we're doing surgery. We haven't stopped because of COVID. I wish that people's pain would stop because of COVID, then we could stop treating. But the reality is that people still have pain and they want to get fixed. So we have everybody sign a COVID waiver before they come here. And in the COVID waiver, it obviously says, you know, you could get COVID, but we've not had that happen, thank God. All right, you can see a tear right here at the back of the disc, literally into the epidural space. And there's some herniated disc material, and I'm just trying to assess how much there is, because I don't want to go too far, but I also want to get all the herniation I can. And that stuff there is kind of like sitting right on the spinal cord. So I definitely want to get as much out as I can. This side looks good, but it's just right there and maybe a little bit off to the foramen again on her left side that I need to be paying attention to. This little guy right here is a troublemaker. Yeah, we would never operate on someone with an active COVID infection unless it was an emergency for some reason. But we would want everyone to be safe, and you know, COVID is serious, obviously, and if you have a COVID infection, it's going to affect your ability to be oxygenated and ventilated. So. Just about done. This is scarred up. You can see the fibers of the posterior ligament right there. Got a lot of scar tissue on them from this herniation and chronic inflammation. But just working my way across the back of the disc where the bulge was, where the herniation was, back out the foramen. I don't see any more herniation in there. Just about done here. I think I'm done. I don't see anything putting pressure on the spinal cord. Right there is the only area that I may have a little. And I'm literally peeling the herniation off the spinal cord here with the laser. So this shows you how much faith I have in this laser. It literally goes out at 0.5 millimeter. 0.5 millimeter. So I can get real close to the spinal cord and the dura, and I can have confidence that my laser won't do anything like shoot across the room. That's about it. You can see the indentation from that herniation in the posterior ligament. Now my goal here is not to gild the lily. My goal is to decompress and treat the tear, get rid of the neck pain, the arm symptoms, and I think I've accomplished that. These are bone spurs. They're not doing anything. I'm not going to mess with them because that will only lead to bleeding that's unnecessary. That's it. We're done. I'm going to come out. Let me just sweep across one more time. Make sure I didn't miss anything. Looks good. Looks real good. All right, done.
Lights on, please. Thank you. Scope off, please.
Scope off. Let's get this stopped. All right, you have any questions I can answer? So that surgery was to repair a herniated disc without fusing, without metal, without open surgery, without bleeding, without pain. This patient will literally have Tylenol for their pain. There's no narcotics or opioids for this kind of spine surgery. That's one of the major advantages over open surgery. So if this patient had an ACDF or an artificial disc, they would have to take narcotic painkillers. They would probably be in the hospital for the surgery. This is outpatient surgery. This patient's going home in an hour. As long as my anesthesiologist gets her awake in an hour. All right, we have any more irrigation? I need the needle. Thank you. Luis, you've done an amazing job as always. Thank you. All right, so we're done irrigating. And now I'm going to put a little medicine. And this, what we're using is an antiseptic. It's betadine. It was developed by NASA for the astronauts traveling through space, and just to clean and sterilize everything, make sure they didn't bring back any aliens that would take over Earth. All right. We're going to take this tube out now. You ready? I'm going to put a little pressure in case we have any venous bleeding, which I don't expect. We've lost literally 0 blood. I mean, not even a full drop of blood. So normally you're going to lose a lot more blood than that when you do open surgery. A lot of blood. Could be hundreds of milliliters. Let's, I need to suck the juice out of here, the water. I'm just sucking the irrigation out over here, and I'm gonna, the irrigation is clear, there's no blood. We didn't lose not even a single drop of blood, but I'll just put 1 drop. There are 20 drops of blood per milliliter. Most surgeons lose 25 to 100, 150, 200 milliliters of blood for an anterior cervical discectomy infusion, ACDF versus an artificial disc. But we've lost 0 blood. And we've repaired the disc. We're preserving the motion. We're not putting any metal or implants. So we're not making the implant companies rich. They're not going to like me, but they never have, right? Because I don't make them rich with putting metal in. But then again, if you were the patient, you want metal or you want natural? I would want natural. I don't want metal in my neck. I've done over 1,000 ACDFs and artificial discs in my career, 1,000 of these surgeries through the front with metal. And this surgery blows them away. I hope I never have to do another fusion. We actually are doing a fusion. As a matter of fact, I'm doing an ACDF next week or the week after because that patient cannot have the laser surgery. Her neck is just too thick. It's not safe. That patient's neck is probably 4 times as big as this neck here. You're going to have fun with that one. But we'll be doing an open surgery. It's safer. All right, I'm going to come off. There's the incision, folks. You see that? 4 millimeters. Can you see that, Diego?
Yes, we are looking at it right now.
Beautiful. All right. We obviously don't need any sutures. We're just going to put a little Band-Aid, and we're done. We just want to raise awareness around the world of the surgery, that it's available. People don't have to have a big, ugly scar. They don't have to have trouble swallowing after their surgery from the surgery scar. They don't have to have metal in their neck. You know, all that's totally unnecessary. And my prediction is that once insurance companies realize this surgery is available and better, they're going to stop paying for those fusions because they're much more expensive, and they're going to stop paying for artificial discs. So those companies are trying to get all their money out of it now while they can. But what they're doing is they're keeping all the surgeons in the dark about these new technology with the laser that we're doing at Duke Spine. All right, EBL. I'm going to call it 1 drop. No complications. And this was a right approach. DLDR, Duke Laser Disc Repair. C5-6. And I'm very happy. It went really well. All right, we have 1 more surgery to do for you all. It's a back, correct? A bilateral. We're going to go on both sides because they have bilateral pain. All right, type your questions up for me. I'm going to answer them in a couple of minutes. Diego, why don't you run a video? Show them the ACDF versus Deuk laser disc repair so they can see the difference.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with
Hi there. So I'm here with you to answer questions at the end of the surgery. We've just finished doing anterior cervical transdiscal Deuk laser disc repair. And basically, what are we doing here? Well, this is what's going on, just so everyone understands. These are two of the bones in the spine. Let's just say number 5 and number 6, right? Because that's what we operated on today. Well, between those bones is a little cushion called the disc, and the disc has a jelly center with a tough part on the outside. So let's take a look at one of these discs. I take it out, okay? Normally it's flat like that, horizontal. Let's turn it up so you can see the back of the disc pretty well. This is the front of the disc. This is the back of the disc. What you can see is this red stuff was the jelly in the middle, okay? And the patient traumatized their disc with some kind of trauma. I don't know, lifted something heavy or, football injury, who knows? Everybody's story is a little different, but it's easy to tear your discs because they're not that strong. Bones don't break, but discs tear. So when you get a tear in the back of your disc in the containment wall, then the jelly in the center can actually push through that tear and just sit there inside the tear. And there's a little part that's the stalk of a mushroom, and then there's the top part, which is like the cap of a mushroom. So imagine like a little mushroom sitting in there. There's a stalk that starts here and goes out through the tear, and then outside the tear there's a cap. Now, we call the cap the herniation, but it's really a misunderstood thing because yeah, everybody focuses on the cap and is it pushing on a nerve or the spinal cord? Very important, obviously, but we're missing 95% of the cases where the stalk is sitting inside the tear and the tear wants to heal and close off because it doesn't like being torn. It wants to heal itself. The body heals itself. You cut your arm, it's going to heal itself, right? You hurt your liver, drinking too much, it's going to heal itself. Whatever you do to your body responds, it reacts. So when you try to hurt your body, a lot of times it'll try to heal. So when you tear your disc, the disc wants to heal, but it can't heal because now that jelly in the center is now stuck and wedged between the torn edges of the annulus. That's where I come in, folks, with the Deuk laser disc repair. It's the only surgery in the world that actually targets that tear, cleans out the stalk and the cap of the mushroom, the herniation, and then allows the disc to heal and seal over. Now, we can't seal the disc, that's your job after surgery, but we can set everything up to seal. And that's what we did. So this patient had a herniated disc where the back of the disc had that jelly sticking out with the tear, right? So we went through the disc, leaving the entire disc alone. We did not mess with the whole disc. We just went through the disc with our little tube, went past the center, got to the back and docked it right there where the tear was. And you can see the tear on the discogram. And then I used the laser to clean that tear up, and I swept the laser across the back, removing fragments of herniation till it was all gone. It went perfect, and there's no need to do a fusion because unlike open neck surgery, where all these doctors are taking the whole disc out and they're left with the gap between the bones, and you got to stick something in there. So they stick a cage in there, and then they hold it all together with a metal plate, right? That's called an anterior cervical discectomy infusion. You got a metal plate, you got cages, you can see the cages in there. The only reason to do this is because you took the disc out to get to the piece in the back to fix the disc. I can fix the disc endoscopically without taking the disc out. So there's no need for metal or fusion or artificial disc. It's all natural. We're not leaving anything inside except the natural disc, and it will heal, and this patient won't have their pain anymore that they came here with. It's literally the most advanced surgery in the world for herniated discs. So, we have some questions.
Yes. This seems to be an early medical student. He asked, is the pain coming from the compressed nerves or the disc itself? Which you answered. And next is...
Well, let me answer that question. So, one of our viewers asked me, is the pain coming from compressed nerves or the disc itself? The answer is the disc itself. You're correct to question that because everything people are being taught around the world by their surgeons, by medical textbooks, by medical schools, is that pain comes from a pinched nerve. And that is absolutely not true. The neck pain And the headaches that people get from a herniated disc in their neck come from the tear in the back of the disc. They come from this tiny little tear right here, the annular tear. Again, I discovered this, I published it back in 2012. I've known about it for 15 years and I've been treating it for 15 years successfully. Virtually 100% of our patients, their pain goes away. 100%. 100% of the time. And that's because we're treating the source of the pain, which is the tear. What do compressed nerves cause? Compressed nerves cause arm pain. So when you have a compressed or pinched nerve, you're going to get pain down that arm. You're going to get tingling in your fingers, numbness where you can't feel your skin, and even weakness where you can't grab things and hold things. So whenever you see somebody with arm symptoms of weakness, numbness, tingling, or pain, that's from the compressed or irritated nerve, the nerve root. But compressed nerve roots never cause neck pain, never. And irritated nerve roots never cause neck pain. They only cause arm symptoms. So that's what people are wrong about. And it's a huge problem because I'm having to basically reteach everyone the truth, which is that it's a small tear in the back of the disc, which you can actually see on this beautiful model. There's a little tear in the way back. If you look through there, you can see it right there. That's the annular tear. See how red it is? That's all inflammation. Okay, and there's little yellow nerves in there. I had this model specially built to explain the source of the pain. Now, if you look here, okay, you see the tear right there? Sorry about that. I do get calls once in a while. There's a tear in the back of that disc right there. You see the red thing? Okay. Now, watch what happens when somebody picks something heavy up. The jelly pushes out and hits the nerve. That's when you get more neck pain and you get arm symptoms. So arm symptoms, leg symptoms are from pinched nerves. Neck pain, back pain is from the annular tear. Again, that was discovered here at Duke Spine Institute, and we've published it. If you look up in the National Library of Medicine in PubMed, type in Duke laser disc repair, you'll see that we have several surgeries, papers that are published after peer review.
Okay. And our last not question, just a comment. Thank you, Dr. Duke, for being honest and continuing to treat people during these strange times. People still have pain that need to be sorted out. Thank you and God bless.
Yeah, so one of our viewers was just appreciative of the fact that there's doctors like me that are willing to treat patients. COVID, as you know, is a deadly disease. We take it very seriously, but I'm not going to shut down helping people because I'm afraid of COVID. I've got great staff here. I couldn't do this alone, and everybody feels the same way. The real reason is that we actually realize we get we're in a special situation. We get a special gift every day. We get to see people's pain go away that they've lived with for 2, 3, 4, 30, 20, whatever, like decades, that nobody else has been able to cure. And then I can figure out where it's coming from, and then we go in there and fix it. And to be able to make that kind of a difference in someone's life is special. And you can't put that on the shelf. You can't just take it away from people and put it away. That's wrong. It's the wrong thing to do. I wish I could treat everybody in the world. The problem is that these treatments are expensive to do. They're not as expensive as fusions that cost a lot of money with the implants, but they're still very expensive, and I want everyone to have access to this treatment. I really need, to be honest with you, we need to go and talk to Mark Zuckerberg or Bill Gates, some of these very wealthy people that have got billions of dollars they're sitting on, and put that money to good use fixing back and neck pain. Yeah, that's all I have to say. Anything else?
That'll be all, sir.
Okay, we've got one more surgery to follow this one. It's a lower back again, and this patient has 3 herniated discs. Hopefully we'll do it, but the patient has a history of heart disease, which we've already cleared him for, and he's good to go, but the anesthesiologist needs to check him out and make sure today he's good to go because, you know, things change, and his clearance could have been a week ago, and he was fine a week ago, but today maybe the story's different. So anyway, hopefully we've got one more to go, And it's going to be, if it goes, it's going to be 2 discs on one side and then the bottom disc on the other side. So it's a 3-4-4-5 and then a 5-1. I can't remember what side's what's, but we'll get that started up in about 40 minutes. So go grab some Diet Coke and pop yourself some popcorn and bring your friends and come on back. Nice talking to you.